beautiful June evening. I'm Sora. I work in public programs here at MOHAI. To give a visual description of myself, I am a white and East Asian person wearing a black mask with long brown hair, a black shirt, and black pants. We're very excited to have the People of Color Against AIDS Network here tonight, and it's going to be a wonderful program. Before we begin, a few housekeeping notes. If you need a restroom, they're just beyond the deli case to the left and on the left side of the hall. Feel free to meet your needs at any time. History Café is a series presented in partnership with HistoryLink on the third Wednesday of every month. We love partnering with them. Amazing organization. Check them out. As we ground in the space tonight, it's important to acknowledge that here at MOHAI, we're on the historic and contemporary lands and waters of the Suquamish, Duwamish, Muckleshoot, and all Coast Salish people. Historically, Native communities were forcibly removed from this place, with lasting impacts on the people, land, and water. Therefore, it's critical that we hold deep respect and gratitude for their unbroken stewardship of this place. We encourage you to visit the websites of local tribes to learn more about the people whose land you're on. Tonight's moderator is Claudia Lawrence. She works at POCAAN in event planning, fundraising, and development. Prior to POCAAN, she worked as a director at Seattle Against Slavery and this Federal Way Coalition Against Trafficking, as the program's manager for youth suicide prevention at the Seattle Indian Health Board, and as the tribal liaison for Big Brothers and Big Sisters of Washington. When not working, Claudia enjoys hiking, mountain climbing, wildlife photography, and long road trips. Please give her a warm welcome as she introduces the rest of the panelists.
Okay, thank you so much, everybody, and thank you so much for being here, not going out in the beautiful sun. I know it's a real battle. As Sorana said, my name is Claudia Lawrence. My pronouns are she, her, hers. For optimum accessibility, I'll describe how I look. I have brown hair. I'm light-skinned, I wear glasses, I have on a striped shirt and light-colored denim and vintage Doc Marten sandals, which are pretty cool. So I wanted to thank MOHAI today for inviting POCAAN. They actually saw us out, so we're really pleased by that. They recognize that POCAAN has an important and key role in Washington State history, which has been under-recognized. I would agree with that 100%. And I'm so glad that the rest of Washington State is catching up to the amazing work that POCAAN has done. And I appreciate that tonight we'll be putting one more chapter in the story of POCAAN and making it accessible to the entire community. If after you listen to our presentation, you are moved to support POCAAN, you can visit our website at pocaan.org to learn more about how to support us, or you can see me after the event. Okay, I'm going to give you a really brief thumbnail sketch of what POCAAN is. Our panelists, of course, are going to completely flesh that out in a deep dive on the past, present, and future of POCAAN. But just to orient us in the right direction, I'll just give like a one-paragraph introduction. So POCAAN is the People of Color Against AIDS Network, as Sorana said. We were established in 1987, so we're one of the oldest nonprofits in the Seattle area, almost 40 years old. We're a multicultural social service health equity agency, serving marginalized communities in Seattle, King County, and at one time throughout Washington State. We'll be there again. The agency seeks programming that addresses substance abuse, incarceration, homelessness, sexually transmitted diseases, racism, sexism, homophobia, and other factors that further contribute to community marginalization and health disparities. Okay, so now I'm going to introduce our three panelists. I'll do all of them in the beginning, so we'll just have to kind of remember each person as they speak. Of course, the title of the presentation is POCAAN, Past, Present, and Future. So each of our three speakers is going to address one part of that. One will present on the past of POCAAN, one the current what the work that POCAAN is currently doing, and then our last speaker will talk about the future of POCAAN and the vision for it moving forward. So the person that will be speaking on our panel on POCAAN's past is Miss Alia Messiah. She's sitting in the center. Alia is our longest serving POCAAN staff person. As we mentioned before, POCAAN was founded in 1987 and is nearly 40 years old. Ms. Alia has been with POCAAN since 1990. So she came on board 3 years after the organization was founded and has been with POCAAN for 34 years. So she is truly a repository of its history, as you'll find out in a minute. Alia started at POCAAN in the role of community-based service liaison, which was a case management program that was a collaboration between POCAAN, the newly formed POCAAN, and the Department of Public Health for Seattle and King County. As such, Alia has been working in the areas since then of HIV/AIDS awareness, education, prevention, and treatment since AIDS first hit the U.S. She served in that role for 7 years, doing direct service work with African Americans and other BIPOC members of our community. In these early years, she worked with many HIV plus women and HIV plus children through the 1990s, during, as I'm sure many of you will know or remember, a very tragic and difficult period of time. When HIV was at its most difficult period. Excuse me. Alia worked on the AIDS clinical trials, educating the African American and other POC communities on AIDS awareness, prevention, and treatment, and helping people of color navigate their participation in AIDS clinical trials. Her work also during this time included education and prevention within Washington state jails and prisons for women. She also served in the Minority AIDS Initiative, a national program doing advocacy work for African Americans. It's also known as the MAI. Following that work, Alia founded the Medical Case Management Program at POCAAN, which is still ongoing. This was a program that serves people who are both newly diagnosed and living with HIV and AIDS. Also during this time, Alia worked on what we call the GOTS program, which is an acronym for Get Off the Streets. It was a diversion program to stop criminal recidivism within BIPOC communities. Currently, Alia is POCAAN's deputy director, and she runs one of POCAAN's largest and most complex programs, the Senior Mobile Medical Outreach Program, also known as SAGE. SAGE dispatches a full medical team to senior centers and other places in King County to provide free medical care to seniors and to connect them with further needed medical and social services. Alia Messiah is a Seattle native, born and raised here. The second person that will be speaking this evening is directly next to me. That's Mr. Ernest Walker. He is our program director, and I'll give a brief bio on him as well. Ernest Walker is a dedicated and accomplished public health professional with over 25 years of experience focusing on addressing social determinants of health impacted by HIV and AIDS. His career journey began in 1998 when he started working at POCAAN as a program coordinator, providing crucial prevention services to Black MSM, which stands for Men Having Sex with Men, I believe, yes, and transgender women. Following his impactful work at POCAAN, Ernest moved on to the Minority AIDS Project in Los Angeles, California, where he served as the manager of HIV prevention services from 2000 to 2002. In 2003, he transitioned to Washington, D.C. to join Us Helping Us People, Inc., where he held various roles, including Director of Programs and Chief Operating Officer until 2017. In 2019, Ernest took on the role of Acting Executive Director at NASM, further expanding his leadership and impact in the field of public health. He then became the co-executive director of Lost and Found Youth, an Atlanta-based organization directed dedicated to supporting homeless LGBTQ youth. In 2020, Ernest joined the Men's Health Foundation as the director of the SoCal Club in Los Angeles, focusing on addressing the needs of Black and Brown youth in South Central LA. In 2023, he returned to his roots at POCAAN to serve as the program director, continuing his prevention efforts in the community where his journey began. Ernest holds a Bachelor of Science in Civil Engineering from the University of Washington and a Master's in Public Health from Trinity University. His passion for public health, his dedication to serving marginalized communities, and his leadership in addressing social determinants of health have made Ernest a very respected figure in the field of public health. Our last panelist that I'll be introducing is on the far right. That is Bishop Stephen Sawyer. Bishop Sawyer is a human rights advocate, a community leader, an entrepreneur, and a national religious trailblazer. Currently, Stephen works as the executive director of POCAAN, formerly known as the People of Color Against AIDS Network. And we have pivoted a bit from saying People of Color Against AIDS Network and going more by the acronym of POCAAN, which our panelists will explain more about, but basically it's because we've expanded our programs to other equity issues beyond that. We have over a dozen programs which Ernest will present on. So that's why we say formerly known as People of Color Against AIDS Network. So his work also included interaction and involvement with a number of local and national civic and social organizations focused on human rights, economic empowerment, social justice, and HIV/AIDS advocacy. These organizations include the HRC, the Human Rights Campaign, the Center for American Progress, the National Black Justice Coalition, the Center for Black Equity, the National Gay and Lesbian Task Force, and the Out in Front LGBTQIA Leadership Development Program. And I will say, I shared Bishop Sawyer's bio with another person on the staff who works closely with him. And he started writing more and more things that Bishop Sawyer does. And I said, our whole 90 minutes will be his biography, so I have to stop it there. But believe me, he does a ton of other work. He's a really amazing person. Stephen's academic studies include a Bachelor of Arts degree in Business Administration with a concentration in organizational management. He has a Master of Divinity with a concentration in Global Development and Justice from Multnomah University in Portland, Oregon. Bishop Sawyer can best be described as a leader and a trailblazer with a heart to see his community healed and whole. His motto is sharing with the organization, promoting health, mobilizing community, and transforming lives. Mm-hmm. So with no further ado, we're going to go to our panel. I just would like them to please remember when you introduce yourselves to say your pronouns, do a brief description for accessibility, and to speak rather slowly so our interpreter can keep up. So Ms. Alia, take it away.
Thank you. My name is Alia Messiah, and I have black hair, and I'm wearing black glasses. I have on a shirt that has black hearts in it, on a beige shirt, wearing a vest, and some pants that have little sparkles in them. My pronouns are she and her. All right. So, wow, this is awesome to be here to talk about POCAAN continuously, because it's been just an awesome experience and continues to be. And starting in POCAAN in 1990, I was introduced to POCAAN through my sister, Sheila Robinson, who is definitely a legacy of POCAAN. She gave me the application, and when I saw it, I said, this is my job. And so I just knew it was my job, and worked toward that and was able and got the job. But to start to tell you that how POCAAN started in 1984, there was some community members came together to talk about what was happening with in Seattle with HIV and AIDS. Some individuals had gone to a conference back east, and they came back and shared the information, and they got together and said they had to do something. We have to do something, and for the fact that there was nobody serving African Americans in this area that were HIV positive. And so that was the whole premise, to really work to help start something that would help people be educated about HIV and AIDS, and to those who were also being identified as positive. So so it took them a few years, so that's why we say 1984 is our start, because that's when it organized. 1987 is when it was launched, and then with that, the hiring of Catlin Fullwood, who was the first executive director, dynamic, awesome woman that had a vision. It's like her visionary, like Stephen, just to propel POCAAN and to do the work. She hired my sister Sheila, who had lived experience in the things that she had done. Was her lived experience, having been institutionalized, having worked in the community, in the sex work, sex trade, had substance use issues, and was then in recovery after 26 years. And Catlin saw in her what she needed to see to bring her on. She also hired, some of you may know the name Donna Reed, but her name is My 8 now. But she hired My 8 to do the coordination of educating within the different partnerships. And Sheila was an outreach worker. She hired Judith, as she's our Latino sister, and she was outreach worker. Her and Sheila worked together, and also, I can't get his name. We followed each other. He was at camp. I came to camp. He came to POCAAN, then I came to POCAAN, and then he went on to work for Larry Gossett. I just can't call his name. Know him well though. So the three outreach workers took. The initial thing was to learn about HIV and AIDS. Nobody really knew the information, so they had to study and learn and to be able to go out and do this work and spread and do the education and the prevention work that needed to be done so desperately. And so they did together. They learned and excuse me, and took off into the streets doing the work. And Sheila being a leader because of her connections in the community to go into areas and places that others would not go. And so they went and they took the information, the condoms, they took all of the brochures that finally, when they got developed, they took the information to be able to know, so people could know what they needed to know about HIV and AIDS and how to protect themselves. What happened also at that time was that they started identifying individuals that were HIV positive. And so there was a gap there because they were doing outreach, and they found themselves doing case management work because of all of the needs. And so Catlin collaborated with the health department, and that's what's my job. That's how I was hired to go to become the community-based service liaison, working with the women and children that are HIV positive and in the community. So a lot of collaboration, a lot of partnerships, a lot of work had to be done in those days. The programs just continued to grow with POCAAN. At the same time, there was Phyllis Little, who was our past ED. She's passed on at this time. Blessings to her. She was hired in as the person who headed up going into the prisons across the state, and others were hired. Everybody always had teams. We worked as teams, but so taking the message of HIV prevention and education had to go into the prisons, because that's where another high-risk population was happening everywhere. And so going across the nation, the states doing that work. Next things were hired different individuals with POCAAN's name at the time being People of Color Against AIDS Network. Different populations, BIPOC persons were hired at POCAAN to do the work in the various communities, the Latino communities, the Asian Island Pacificers, the Native American, the women who are HIV positive, babes. And so these individuals were hired, and they worked in their community doing the work. And as they did that, coalitions were developed. And the coalitions came under POCAAN because they were not vested as 501c3s at the time, but they came under POCAAN's umbrella. And the coalitions, that's how we went into all of the areas with the people of color doing the work for all the different populations that was so desperately needed. And so that the development just continued to grow and grow as those groups did this work, and in their communities. There was some that, I mean, the coalitions were able to become, some of them became their own 501c3s. Etrohumanis today was a coalition of POCAAN. The Babes organization, which is an organization that works with women that are HIV positive, that does awesome work all the way around. They were a coalition of POCAAN. Sister to Sister, Brother to Brother were coalitions of POCAAN. And a couple others that just really, being able to know that was a way to spread the word, to do the education and the information was like an excellent, I don't know, just that vision, to be able to have that vision and to see that happening. As we continue to grow, the education materials were being developed. We got grants to be able to do the educational materials, and special materials were developed. If any of you know from back when the AIDS News, it was a little, kind of like a little cartoon magazine, but it was education of HIV and prevention work, and it was awesome. It was all across the nation, all out of the country as well. That AIDS News traveled and was ordered. POCAAN had a whole material section that was developed, and so with that, through a grant, and with that, the information was able to just we had all kinds of literature, brochures and pamphlets and information that was all very, very highly published and very informational. The Latino population community developed some awesome material also. They call it the Fotella, and the stories. They would have stories in their little papers, and in the languages. The language POCAAN made different brochures in all different languages also, because we had the different coalitions that spoke the different languages. So the education and prevention and outreach work was POCAAN's number one focus, was to be able to teach and educate and support those that needed it, that desperately, that were not being identified and helped in that way. The one thing with POCAAN was that we always did work and personalize it because we're people of color working with people of color. So we know that how difficult it is to be able to get good service, to be able to be treated fairly and with equity, and get the support you really need. So for those of us working with POCAAN, and we always made sure that if someone comes and continue to do that, Stephen has given it a name called the red carpet handoff. And it's awesome because that's been happening with POCAAN since the beginning of POCAAN. We've always treated people and made sure they got what they needed. If they are referred to someplace, then we know where we are referring them. There's someone there to help them. We may take them there if necessarily, to make sure they get what they need, because HIV and the stigma around HIV at that time and the continuation of it, was very, very awful and hard. My job working with the community HIV positive individuals, I always said that the two things that were the hardest, I mean, someone having HIV, having to work through that and learn and be able to know what they needed to know was one thing, but the difficulty was stigma and substance use. Those two things caused so much havoc for being able to really get people the help that they needed to overcome, because the stigma was so vast in every way you can imagine, from in families, in the neighborhoods, in schools, no matter where, the stigma was there because HIV was the fear factor. You get HIV, you're going to die. And so the individual with HIV has to learn how to cope and be able to deal with that their own selves with love and support, and then having to so often use substances because they need to numb themselves, because their mental health is so shattered, and the damages of what HIV is doing to them. So those things were things that we had to have to work with and work and help and support no matter what, and because so many were dying and the medicine wasn't there the way it is today. It was taking lots of AZT that was doing very little. Next medicine, DDI, didn't do a lot, so it wasn't until later when medication got combined and we have the great medications that we have today, which may be spoken about. But the difficulty was vast, and the programs continue to grow with POCAAN in that the brother to brother and sister to sister were organizations that started with the women, LGBTQ women, lesbians, and brothers, brother to brother, men who have sex with men, MSM, and transgenders. When those organizations were really supported and took off, because HIV, as we know, was dominant with the populations, and so we had to the work being done was awesome, because there were events that were put on constantly that brought about awareness and education and support. Excuse me. So the events, the drag shows, at the different places of entertainment, the conferences that the Sister to Sister held, the education was ongoing. The groups were large. There was large numbers, in the hundreds of the brothers that came out and the sisters that came out and supported the sister to sister and brother to brother. And that's the organizations that was happening across the nation. There was Raymond Dumas. He was one of our leaders in working in the LGBTQ community with brother to brother, and he was able to initiate those things and start those programs for POCAAN and the connection happen across the nation with that. Also, I just want to share another really important program that my sister Sheila Robinson was able to bring into existence also, was a program that was called, it worked with the women who had sex with, who had sex for drugs and money, known as prostitutes, but we call them sex workers. And so the program hired, because POCAAN started a program called peer education, and that was awesome as well, and built and continued to build on what we're doing today. So the peer education program, where they worked we hired young people that were in schools and paid them $10 an hour. They worked, which was really good money back in the 90s, right? They worked part-time, but they just took and got the information out to their peers, whoever their peers were. They were educated, they were given the backpacks, and they went forth and did the education. And the same thing would happen with the program that Sheila started, Girlfriends Talking. Powerful program, working with the women, hired those women that wanted to get educated, got the education, and went into their communities and doing the same work in education and prevention. That they wanted to get help to come out of that lifestyle, they could get help. If they didn't, disrespected them, and they did their work and did a good job with POCAAN. And so there's many things that have happened that has caused the foundation of this program, of this agency, and there's thousands of people who have come through POCAAN in different ways as staff, as clients. It's just awesome, and still today we continue to do this work, and I'm really want to say that I'm so thankful and proud. To be at a place for 34 years is a long time, right? Yeah. But I've done many things, and I'm so grateful because I feel blessed to be able to be at POCAAN, more so than the fact that this is just a job I do. I feel really, really fortunate to be able to be at POCAAN for all these years, to do this work and to help the communities, because it is very, very important to me. I'm probably over my 3 minutes. Thank you. Oh, okay. I guess just saying that, is that people that work at POCAAN, have come to POCAAN, the commitment is that's what I've always had, passion and commitment. The commitment is what's needed, and the passion is what's needed. And when we have that, we have the successes that we have, and they're ongoing in every program that we've had, and everyone that we continue to have at this time. So, being able to know that we can do the work that needs to be done for our communities, for the Black communities, for all of the BIPOC communities is special, because it's not happening from any other program in this Pacific Northwest. So that's all I have to say. Thank you so much.
All right. My name is Ernest Walker. I am the programs director at POCAAN. Our pronouns are he, him, his. I'm brown skinned, bald headed. I need glasses. I have on a pink shirt, black pants, pink socks, and black shoes. And so I get the privilege of talking about POCAAN's present, right? Right now, POCAAN has went through a major transition, right? From, doing a lot of the grassroots services and programs to really moving into medical and treatment, right? And I'm going to talk about some of the things that we've done. So over 40 years, of services in the community here in Seattle and in our surrounding cities, because we were in, like Alia said, Eastern Washington, Tacoma, so we've done a lot of work in the state of Washington. We've served over 1,200 clients a year in our day-to-day services, right? And then in our outreach services, we do over 2,000 outreach recruitment and in-reach and outreach in the community. And that says a lot about what we are and what we do. We go out in the community, we build rapport, and then we stay consistent. You know, we say what we mean and we mean what we say, and you can always count on us coming back and coming back and coming back until you're ready. A lot of times, the first few times, folks aren't ready to access the service or get the help that they know they need, but when they're ready, our arms are open, we're always there, and we provide those stellar services that keep folks coming back to POCAAN. You know, we have a plethora of programs, so over 13 programs that we have to offer. We have the MOCA Prep Clinic, which is really one of our staple new program, where we provide prep to the community, right? And especially for Black, MSMs, trans, and mainly now heterosexuals. We're providing a lot of prep to heterosexuals. HIV infections are coming, and showing up in that community more so now as we're doing testing out in the community. So we're getting folks on prep in the community. We have our K2 program, which is our Ryan White a HIV positive program, case management program, where we provide case management and supportive services to our HIV positive clients and getting them connected to care and services and really helping them create those plans to stay undetectable and making sure that their social support needs are being met. We have CURB, which is one of our programs that's been around for a while, and it's really that program that really helps our youth in the community really look at what they're doing and how do they stay on the positive side, right? And when they're having challenges with going to jail or family members going to jails and it bothers them, they come to our programs to help them address those issues, whether if it's helping them get off substance use, helping them with their housing, helping them with their cases if they're one of the ones that are actually, going to jail or dealing with the jail systems. We have Breaking the Change, which is our non-medical case management program, where for those who are HIV positive, they're working great with doing their medical stuff, but they need the social support. So, support groups or, having someone that they need to talk to help guide and listen to, because we don't always have those people we can run to and talk to when we're talking about HIV. Because believe it or not, it's still a taboo in Black families, right? Black churches. We still can't really talk about those things openly and get a really, really good response, favorable to help us continue to move through, our challenges as folks who are HIV positive, right? Then our VOCA, we have a VOCA program, which is Victims of Criminal Act. That program really looks at, folks who are being challenged with being victims, right? Whether it's the sex trade, whether it's, being forced into prostitution, where it's being in domestic violence relationships, and that's male or female. And, I don't want people to always think that that's always a woman thing. Men are in domestic violence situations as well, whether we're talking about if it's a gay relationship or a straight relationship, right? We also have BSK, which is our Best Starts for Kids, and it's really looking at getting kids from becoming homeless. So it's a homelessness program. So if you're under 24, if you're a youth that's 24 that's living by yourself, we help you stay above par and keep you so that you don't become homeless. And if you are a parent that have youth that are under 24 in the household, we do the exact same for them. We keep them in the household. We make sure that we help them keep their lights on, help them pay their rent, but also help create a plan on how do you make sure that you don't go back there, right? We make sure that we help create budget plans, helping them with their banking, helping them with those things that are really going to help guide them and help them get them, and then connecting to some of those free services so that, food banks are out there. There are places that are, really helping pay light bills. So making sure that we make those connections. We have SAGE, which is our program that deals with our senior mobile medical outreach program. And so we go to the community centers for the senior centers and really address their medical need. We know that as going to the doctor, what I've learned is that when you go to the doctor, they're going to address that one thing you're going to the doctor for. If you have something else, they're sending you to make an appointment to come back to do that. Unless it's an emergency, then they'll address it maybe and then send you to the emergency to get it addressed, right? So for us, what we do is we address all their needs. We do an assessment, right? And then we start talking about what are some of your challenges as a senior what are your health issues, right? What are your social service issues, right? We also have a case manager. So we have 2 nurse practitioners, and we also have a medical, and we have a medical case manager. And then we're also looking to hire, if you all know, MA, driver, and a CNA. So we're looking to hire more medical staff that can help support the senior mobile medical team, but also our prep clinic too, right? Our prep clinic has expanded, so we're also doing treatment. We're on the medical side too. So our medical providers are providing medical services to people who are HIV positive, and we're treating all of the medical needs of the client, whether it's STI, hypertension, high blood pressure, hypertension. Our medical providers are there to address those issues as well. We have an HIV testing program, an STI screening program where we go out in the community and provide HIV and STI testing and screening, and we also do treatment. Like I said, we have the providers, so we're able to treat those clients who become positive with any of the STIs and or those who are HIV positive and getting them into care. And then one of our newest program is our biohazard program, right? And so we're really looking at how do people take care of their biohazard needs? So being able to set up events and activities where people can bring their stuff and drop them off, and then the county will come and pick those things up, and we will package them in a way that needs to be packaged for them to be taken away. So, and then the last thing what we're really excited about is our Stephen E. Wallace Research Center, right? So we are doing research on a national level now, where we're looking at disparities in community and really putting research behind it so that we can show how things should be done in the Black community, right? And we're also, being, PIs on those, so principal investigators now. So we're actually doing our own research, right? And so that's really, really groundbreaking especially for Blacks. Folks, especially for a Black community-based organization. And so we're excited about that. So Stephen E. Wallace was one of our board members who worked at the Fred Hutch Center, and he was a really pillar in the community around making sure that Black research was happening in Black communities, and he was driving the force home, and he passed away, and he was one of our board members, and so we had to do the honor of really making sure that we honored him as turning our research center into being named after him. And so we're really excited. Hopefully you all get to see some more stuff coming down the pipeline around the work that we're going to be doing. We're doing some community investigation stuff. We're doing some working into the jail systems for folks who are HIV positive and making sure that their care is happening as a continuum. So while they're in jail, but then also when they get out, we have peer navigators that will work with them to keep them, continuously getting the care and the need and the supportive services that they need. So we're really, really excited about that program. So, as we're looking at what makes POCAAN so special, it's our outreach and our community engagement. We do that, hands down. We're great at it, and that's what keeps people coming back. We build rapport, we build relationships. We really talk about how do you get your needs met? Because it's coming from the community. We do the needs assessment, we do our community surveys, we do our client satisfaction surveys, and we address the needs, right? And then we go to the health department or any of the funders and fight for that, right? Because if we're not fighting for it, who's going to fight for them? And so that was one of the main reasons why I came back to POCAAN, was because born and raised in Seattle, and I know that there's a disparity here. And there is a lot of inequality. And POCAAN has always been one to fight against inequality, making sure that our needs are being met in the city. And we're trying to bring our community back into the city. We're being forced outside the city. We can't afford to live in the city. Even some of us who make decent salaries can't afford to live in the city, unless it's dual incomes, right? And nowadays, a lot of us are single. Right? And so trying to live in the city is really difficult, right? And then you make a little bit above poverty level, so you can't get in any of the low income programs, right? And then, you can't afford to live in the city right above the poverty level. We know that if you ain't making 150 and higher, and that's on the low end, to be able to really survive and thrive in the city, right? And so we're working in the outskirts, Renton, Burien, Federal Way, Auburn, Des Moines. This is my city, so I know them all, right? And then we're also in Tacoma, right? We aren't funded to work in Tacoma, but definitely we're in Tacoma because we know that that's where the epidemic is, right? And then we need to make sure that we are addressing those needs in Tacoma area. As we look at our rates and we look at how we are addressing these things, and we're looking at our demographics. So 40% are LGBTQI, 20% are in transitional housing, 8% mental health issues, and we know that is a low number for us because mental health, we know we have mental health issues. It's hard to get folks into mental health issues, especially when you come from families that are saying, what happens in this house stays in this house, right? So we're trying to break barriers to let folks know that it's healthy to talk to a mental health professional and address some of your mental health needs. And we're really pushing that this year between mental health and substance use because those are the things that are driving 20% are in the justice system and 25% homeless. And we know that it's really higher than that. But those are just the ones we've been able to reach, right? And we're looking to reach more individuals as we are addressing the community needs. And if we're talking about past and present future around HIV, we are really looking at an epidemic in our community. And it's really bad because as numbers are going down, our numbers are going up. They're not going down when we're talking about black and brown trans women that are black, right? And then even in the Hispanic community, the same thing. Those numbers are not going down. On a national level, yes, it's going down. But on a local level, our numbers are not going down in the communities of color, especially Hispanic and black and women, right? And so we want to make sure that, we are addressing those needs and those services and programs are there for them. How do I get my needs met if I don't know where to go to get them met, right? And I'm afraid to go talk to my doctor about it. I can't talk to none of my friends about it because I'm ashamed, right? So we're dealing with shame, right? Stigma's the biggest killer of them all, right? And why is after 40 years of HIV, why are we still dealing with stigma? A lot of it has to do with our community, our own community. And then outside of our community, it's making it even worse because you can't even find places to go to address those things. And if they're out there, it's not highly publicized for folks to go and access it. And so we want to make sure that we're on the news, right? We're on the billboards, we're on the radio. We're on social media platforms because that's where everybody is. Don't anybody watch TV no more. Don't anybody watch TV no more, right? And so, where we are now, I think one of the biggest things for us is that we're at a place that we're going nowhere but up, right? We're at a space where our executive director and the executive team is really looking at how do we make sure that we are reaching all avenues when it comes to equality for black folks in the city of Seattle, and the surrounding cities. And how do we do that? Is that we believe in partnerships. We gotta partner. And we have to hold our partners accountable around, you gotta do your part too. Right? As we fight, you got to fight alongside of us. And sometimes you got to fight in front of us because they'll listen to you before they listen to us, and we'll come swinging behind you, right? So, we believe in making sure that when I talk about swing, that means bringing the data, bringing the information, showing them that this is why you got to get behind us, this is why you got to support us, and this is why we got to put money where the need is. If we're talking about equality and we're talking about, really addressing social justice, we got to make sure that we're addressing those types of things as a community, and we got to do it together. And so with that, I'm going to allow Stephen to really take us home because, Stephen is really going to really talk about some really good, favorable things in the community that's going to happen.
Thank you, Alia and Ernest. So again, my name is Stephen Sawyer, he, him pronouns. I am the executive director of POCAAN. For what's coming soon, I'll tell you what I'm wearing. I have on a bluish gray suit with a blue shirt and a purple-ish, blue-ish, not beige, but mauve-colored tie with little flowers in it. Blue is my favorite color, so I wear a lot of blue. I have on blue Oxfords shoes. I'm a dark-skinned man of some age. I just turned 54 and proud of it. And, you know, I am honored to do this work alongside some great community advocates. They're not just staff. Most of the individuals that work with us are advocates to their communities. They come from the communities that we're working in and make a great effort to keep us on our toes and keep us moving in the direction that we need to. Now, you've heard about our past. POCAAN has this rich past of almost over 40 years. It was a statewide organization at one point and had 5 offices across the state that was doing work, particularly in communities of color, BIPOC communities. We have, like any organization, right, there's an ebb and a flow that happens. And so we moved from that and began to do some more specialized work as a lot of these coalitions that were a part of us went off to be their own entity and got their own funding and did work in their own different communities. We began to specialize and to drill down on particularly Black and brown communities. And I think where we are today is we really came to this point of understanding, one, that we're most effective in our outreach, like Ernest has said, that when we're able to get into communities and take the services that we offer to communities, we see a better response to that. When I came along about 8 years ago, we were really an organization that I think was kind of on the cuffs. We really had not made the turn, particularly as it pertains to HIV prevention, which has moved to a biomedical prevention is the key to HIV prevention at this point. And we had not made that turn very well. And so we made some myself, I was on the board, and the old ED, Phyllis Little, transitioned off. And the board really made some poignant decisions that we needed to figure out how do we engage the biomedical intervention and include that into our arsenal of, if you will, of our toolkit for prevention for our community. And I think it was really critical, and still is at a very critical point. I think as I was coming on, the statistics around Seattle had just hit. So Seattle proper had just hit what we call 90-90-90, which means, and it was the first city in the world to hit that. They had identified 90% of the folks that were HIV positive. 90% of those were on medications, right? And 90% of those were virally suppressed, which means they could not pass the virus to anyone else, even if they had engaged with someone. But at the same time, the statistics particularly for Black MSM, was 1 in 2 was going to be positive by the time they were 30. And what we realized is that in the center of the city, right, because of gentrification, a lot of communities of color were being pushed out, was also contributing to this meeting from our perspective, 90-90-90. But yet we had an even bigger crisis on our hand as it pertains to reaching African American and Latinos. And so we really began to think about how we were going to create and include that biomedical prevention into our work and begin to think about how we would form a clinic. And so that's been one of our biggest pushes, particularly around HIV prevention. And so we were lucky enough and blessed enough to partner with the University of Washington, Dr. Joanne Steckler, and a few other folks, Dr. Stephen Wallace, who you heard him mentioned before, to form a clinic, and one of the first of its kind, but definitely the only one in the state of Washington that was focusing on really communities of color, particularly hounding and drilling down on Black MSM and begin to do that work. And that really has laid a foundation for where where our agency and how our agency has grown. We've grown and expanded. I think very early on, again, we figured out that because of our outreach that we couldn't just address folks' immediate health needs, that we had to provide wraparound services. Because the same person that was struggling with their HIV status, they also were struggling with homelessness. They also were struggling with food insecurity. They also were struggling with being underemployed or unemployed. And so we had to begin to develop these wraparound services that would help tailor interventions that would help them succeed as a whole person. And so that's kind of where the red carpet mentality has come from, right? That as we see clients come in the door, we want to be able to help them as a total person and not just a particular part, right? You're not just your status, you're not just your employment status or your HIV status or your housing status, but you're a total person and tell us what you need. And so then we try to either find those resources to do that, or we have those resources in-house to address that. And so as we think about the growth and the future of the organization, what we have realized is that for us, it is very critical that we provide clinical services to match the work that needs to be done in our community. And so right now, we're in the process of expanding our PrEP clinic. We're expanding work with our providers. We have two wonderful providers on staff, as well as an MA that really kind of help us do this work. And so not only we're providing a PrEP clinic, but we have a full clinic that provides full clinical services to individuals that are HIV positive. And we're expanding that to do some gender affirming care and to do some wraparound healthcare services for individuals that want to seek those services, particularly from a place that understands kind of where they're coming from and again, doesn't just see them as a number. I am lucky and privileged that I'm often asked to sit on panels at some of our biggest medical complexes here in the Seattle region. And oftentimes, what I will tell, and they'll ask me to come in and speak to maybe like first-year interns or whatnot, and to talk to them about community and how best to engage with community. And what I often tell them is that one of the things that you have to be so very aware of is that medicine is a science, but it's also an art. And I think somewhere along the way, in bringing all of our technology into the medical field, we've lost that nurturing and caring and that bedside manner that has long served us and made people feel seen and heard. And so oftentimes now, you have your HMOs and all of that, and you get your 15 minutes and they're moving you in and out, and it's almost like an assembly line. And I think particularly for people of color who've been underserved for so long, to be caught up in that system, to feel like you're a cog in a wheel, it does more damage than it does good. And so trying to work from a perspective of healing and wholeness and getting the clients to understand that we see them as a total person. And I think providing those level of service, that level of cultural competence is what we're good at. And so we want to expand that and broaden that. And I think that pairs well with what we see on our social service side. So we're building out, like I said, this clinical service arm that will be a federally recognized health center look-alike. And so that's our very next step. But also pairing that with our social services, right? So that we can also be able to provide those wraparound services. One of the biggest issues of our day and of our time is probably homelessness here in Seattle. I will tell you 95% or more of the people that we see that come through our doors, no matter what their issue might be or whatever our perceived issue of them might be, whether it's their HIV status or their mental health, they're coming looking for housing assistance. And so we really have tried to build out some services to address that. I think one of our big dreams and hopes is to create what we're calling the MOCA Village, where we can begin to house people, in a long-term transitional way, right, that will help them be able to address some of their health needs. I think health, for us, health is it's a human right issue, but it's also a health issue. And I think people can't you can't ask someone to get on antiretrovirals and take a pill a day when they don't know where they're gonna live or how are they gonna eat, right? And so, there are really, we're really focusing in on that and how we can become a part of the solution for housing, particularly here in Seattle and across the state. And so our dream is to create this village where we would provide transitional housing, long-term transitional housing, and at the center of that have our clinic, where it can be centrally located, right? And we know we do service to our entire community, but we also know that our LGBTQ community, particularly our African American and Latino LGBT community, make up the largest homeless demographic and bear the burden of that disproportionately. And so being able to create a safe space for them where they can come in and know that they're loved, they're cared about, and that they can receive all of the services they need in one centrally located area is something that we are hoping to bring to fruition as we move forward. I think the other thing that we really have been working on is that, there is, and this is across the country, we're dealing with immigrants, and as immigrants come in, there are particular needs that they have. Like we have a really large growing African population, and with that, we're seeing a lot of them come in. They know their status, but they need help getting housing. They need help, legal help, right, to become citizens. And there is a lot of underlining services that they need to help further them and to make them contributing part of our society. And so we're really looking at how do we expand that work as we are a sanctuary city, as we say, but a lot of the current laws, a lot of the new things that are coming down the line are taking away from that and making that more difficult for us to do. And so we're trying to figure out how do we engage that more, how do we become a better advocate, but also how do we become a better service provider that can help them be whole and successful and complete. And so that's a critical thing that we're looking at as we go forward. I think the other thing that we're doing is we were once before a statewide agency. So we're looking at how we can do both statewide work, but also do national work. We're a legacy agency, so we're a legacy HIV agency. When I say legacy, that means we were the third agency that was formed in the country to address the needs of the BIPOC community. We are the third. So we started pretty early to address the needs of the BIPOC community, particularly as it pertains to HIV. And so we have a wealth of knowledge that we want to be able to package and to bring to community and help them do that. And I think the last thing I'll talk about really is our Dr. Stefan E. Wallace Research Institute. I think what is so critical if we're going to, particularly as it pertains to HIV, if we're going to bring an end to HIV, we cannot do that without including particularly communities of color who now bear the burden of HIV. We know that in some communities, they are having a decline, and we're seeing great responses, particularly to PrEP and to retrovirals and to all of the tools that we have to fight HIV. But if we're going to do that for other communities, we have to really begin to think about how do we include them in the research. And so we have now about 5 projects that we have under the Dr. Stefan E. Wallace Research Institute, and we're expanding that. And I think some of that work is about working with communities so that we can break down some of the barriers that we know that particularly African American communities may have to research. The country's not had a great track record of how we've done research with particular communities, particularly the African American communities. So we're trying to break down some of that stigma in the community and getting them to engage in research with us. And we're pushing on the scientific side, right, to get researchers to understand that this research and the research that's going to be most effective is the research that we do in partnership and collaboration, that it can't all be about the ivory tower and those folks driving the research, driving the direction, and driving the answers. Because the reality of it is, from our perspective, we feel like community has the answers to what it is that they need if we only give them the voice, the space, and the time, and the finances, right? That we have our own solutions. And so we're really pushing that narrative. I'm lucky enough to sit on one of the community liaison boards to Fred Hutch to also do that. It's part of their Department of Outreach, and so we give direct input to Fred Hutch and how research should be done from their CFAR and how that's best done in community and with community. And so we're lucky enough to be able to have a lot of input about how that should be driven. And so we're expanding that research arm and want to be able to do that research across the country and across the globe. I think we have some partners in Africa that actually have reached out to us, and we're figuring out how we're going to be able to navigate some research that we can do collaboratively with folks from other countries. And so that's our future. That's where we feel like we're headed. I think we're growing, we're expanding, we're going to get bigger and better. We are going to move back to this statewide and global perspective as an agency that's been at the heart of HIV prevention for over 40 years, but also realize that in order to address that need, we have to address the other underlining needs of communities of color. And being able to bring those much needed resources like housing and food, security to folks before you can address their health needs, which is really critical.
Okay, thank you so much to our panel. Aren't they amazing? The work, some of this I hadn't even heard myself, so it's just such an expansive agency, and it's done such a profound amount of work. So that was the presentation part of this evening, and now we welcome questions from our audience for a short period. If anybody has a question, please stand up, or just put your hand up.
Hi, my name is Chris. Ernest, I'm wondering if you could elaborate a little bit more on what exactly is PrEP and how easy and or difficult it is to access?
Thank you, Chris, for asking that question. So PrEP is pre-exposure prophylaxis, and so it's a drug that folks will take, prior to having sex. So getting that drug prescribed from your provider, taking it as it's prescribed, and if you take it as it's prescribed, it will stop you from contracting the HIV virus. And so it's really easy to get if you are going to providers that are really for that. So I would always say, if you want to get on PrEP, really do some research around those places that are supporting that. Right? And then look at your community-based organizations that are doing HIV prevention and education, and really go to them to really look at, how do I start this? And then you can also get more of your questions answered. A lot of times the providers, we love them dearly, but they're not always the most educated on those needs around how, as a Black gay man, how will PrEP work for me? And why should I be on PrEP? A lot of times they will, if they're not for it, they'll say, I'm not prescribing that, I'm not for that, and then it'll really go by the wayside. Or you'll find some that'll say, I'm not really sure, or I don't have a lot of knowledge around it, but, I'll prescribe it. But that doesn't help if I can't get the explanation I need. So we really push for folks to really go and really do some research and really ask the questions for those agencies that are providing it. If you go on to POCAAN.org, you can find it there. If you go on the health department's website, they also have a plethora of agencies that are providing it across the city and the state that folks can go in. And then they have also the website, the prep.org. You can get all the information on the prepapp.org. And, they're also looking at, if you can't afford it, of course, it's free. They will get you PrEP for free, and you don't have to pay for it. If you're insured, if you don't have any insurance, or if you have insurance that's not, you don't know if they're paying for it or not, they'll prescribe it for you and get it to you. And then whoever you're working with, the case manager, can really work with making sure that you get it every time you need it.
And I'm just going to add to that. I think what we also have been doing in our clinic, because yes, PrEP will help us, with HIV, but we also are seeing rises in STIs. And so what we have been using as another means, another tool in our tool belt, and offering it to clients as a way of protection for themselves is DoxyPEP. And DoxyPEP is like PrEP. It will allow you that if you take it, you can take it 72 hours pre or post intercourse, and it'll stop you from getting gonorrhea, chlamydia, what's the other one? Syphilis. So we have been, and it's not new. It's not a new drug. It's an old drug, but it is new, being used kind of in this way as a pre-prophylactic, if you will. And so oftentimes communities of color get these type of interventions last. And what we have been pushing is that we have to make this first for our community, right? And so we have been educating our community about it and talking about it everywhere we talk about PrEP. We talk about DoxyPEP and offer those services to clients.
Absolutely.
So I was just wondering, I'd never heard the statistics that you presented about HIV soaring in the community right now. And then also, I'd never heard this thing about 50% of Black MSNs will have HIV by 30. Is that what I heard?
Yes.
Oh my God. So how has no one heard about this?
The statistics
And how do you
are
get
out
it?
there. I think it is not. Again, I think certain communities have managed well with it, and I think oftentimes, like most things, when they're in certain communities, you just don't hear about it. You just don't have the same level of messaging. They don't put the same amount of money to get it out there and to tell communities about it. I think that has been some of our work, right, to educate our community about their risk. And it's not, one of the things we talk about too, it's not due to doing anything different. It's just how it's social determinants of health, right? Where we live, who we see, right? Our populations are smaller. So it spreads through our community at a much more rapid rate. And in some ways, it's much more difficult for us to access. One of the reasons why we established our PrEP clinic dedicated to the BIPOC community is because in certain other communities, they were being told, no, you're not at high risk, but you're African American and you're a man who has sex with men. And the statistic is 1 in 2. But when you go to the doctor because you said, oh, I haven't had sex in the last 2 months, doesn't mean I'm not going to ever have sex. And they'll tell you, no, we won't put you on PrEP. Or if you hadn't had several STIs or STDs prior to, right, showing a pattern, then they won't subscribe it or prescribe it. And so those are things like that. There's some hindrances and some blocks from folks getting it. And so we've been doing a lot of work, right, to educate the community about the statistics and about what's going on out there, and to really put it to the forefront of people's mind about it. I think in many ways, across the country, though, everywhere we go, and I travel across the country, I do work across the country. With our churches do a lot of HIV work, and so I do a lot of education across the country. But everywhere you go, people think HIV is handled. They think it's done. Like we have some medications that can relatively, get it under control. It's not a thing anymore, but it very much is, particularly in communities of color.
And it's funny that you asked that. It's the health department has these numbers, right? Yeah. This is a national number, not just a Seattle number. Yeah. This is a national number with the 1 in 5. We have smaller community, more virus. That's why we're more susceptible in the Black gay community to contract HIV. Smaller community, more virus. So if you have more virus in the community, you're more susceptible to catch it on the first time, to be exact, right? And so that's why we're really pushing getting folks on DoxyPep, getting people on PrEP. If you're HIV positive, getting you into care, getting you virally suppressed and get on the antiretroviral. But then also, like Stephen said, addressing those social determinants of health issues, housing, food, transportation. I mean, community environment. Your environment puts some of us at risk.
Yeah. Stress.
Stress, yeah.
Stress.
Mental health.
Yeah,
Mental health, sure.
Yes.
Hello, I have a question coming from our live stream. It is a fact-finding question. Somebody is hoping to find out whether or not anyone on the panel can verify if a Charlotte Harris worked at POCAAN around 1992.
Ms. Ollie?
I believe so. She worked with me. I don't remember her name being Harris, but I know it was Charlotte. She worked as a peer educator. Yeah. Yeah.
Yeah, all right.
Her and her husband both.
Yeah.
She married one of the clients who was her husband. And they got married, and they both were peer educators at POCAAN under our advocacy in our Minority AIDS Initiative program. Okay.
I was telling, I was having a conversation prior to, and I was saying, since I've been at POCAAN in the ED, I sit at a lot of external boards and commissions and committees and work groups, and everywhere I go, someone indelibly would come up to me and tell me how they were connected to POCAAN, how they worked with POCAAN in the past, how they got their first start, their first job at POCAAN, particularly for those folks of color. Will make that connection. And oftentimes the next thing they'll say, we're just so happy that you're still around and doing the work.
Yeah.
We're open books, so any other questions we're open to.
I guess I have a question then.
Yeah.
You said that you're expanding into gender affirming care, and I was wondering what that outreach looks like and how that's going.
Yeah, for us, so we work very closely with Lavender Rights Project, with Utopia, and with our trans organizations, really talking about, the services and the needs that are out there. And we, are building that base for those individuals to come to us and tell us what they need and what they want to see. So we don't want to assume anything. We don't want to build a program outside of them. We've always been one where we pull folks that have that lived experience to come in to help build and shape and form the program. And so that's kind of what we're doing. We're having preliminary talks now as we talk about what would a federally recognized health center look like and the components that we'll have to it, and what, like dreaming, like what do we want? What do we want to see on the board, right? And that was one of the things that came from that group and pulling folks together. We also have been working with Queer Power Alliance, who does a lot of work south and talking and pulling in trans communities and doing assessments and talking about, what is the need? What is the need for our community? We do understand that there is some care that folks are going as far as Portland to get. And so we want to make those services available here.
Yeah, and I think the biggest key for us is as we move in that direction around the federally qualified look-alike and looking at how we're expanding the services that we're doing, not still losing the feel of POCAAN. We know that when we move to medical, there are going to be some hard things that they're going to say no to, and they're going to get some pushback around. You can't say no to this because it's helping us do this, right? And it's helping the needs of the community and being able to really help change some of the laws that really block some of the great work that needs to be done in the medical environment. If you think about it, the medical environment is so rigid, right? That it's really hard to really address some of the minute needs that need to be addressed when it comes to folks coming in seeking services. And so what we're trying to do is make sure we keep that community feel. We get people to want to come in and really just say what's on their mind and say how they feel, and then we're able to direct them in-house where they need to go to get some of those needs met, right? And then, or to one of our amazing partners and then we're taking them over to that place, right? So that they're getting that need met.
We still have time for some more questions.
Wow. Thank you so much for being here and what you're saying about the medicine as an art as well as a science is such a balm. I work over at Fred Hutch, and it's so much seems like it's based on liability instead of like helping the person in front of you. And I was wondering if you would speak a little more to the specifics of what you'll find yourself pushing against as far as like regulations in medicine, and how like what specifically can providers, people like CNAs and MAs do to help the individual in front of them.
Yeah, I think when we're looking at research, I think we got to look at the IRBs, right? We got to change some of the language in the IRB that blocks. Oh, IRB. So I can't even remember what it stands for, but it's really the regulations on what you can and cannot do in the research,
Research, yeah.
right? Huh? Investigational Review Board. Thank you. Right? And so it's what you can and cannot do. So it's really helped changing some of those standards and some of those policies on that level. Because then when you do the research, you're able to do those things, right? They're telling you, you can't use these subjects to do this. And so we're saying, okay, with our trans and non-binary individuals, we got to let them be fluid. You know, you can't just say that they can only do this. They're fluid. So we have to put systems into place to where we're addressing the fluidness around their sexuality and what they're doing, and show how the outcome is, whether it's good, bad, or indifferent, so that we can start addressing some of the interventions and programs and services to better meet the need, right? So that's what I'm talking about when we're talking about making some of those changes. But even on the medical side, you know, being able to look at how do you hold, the doctors and the nurses more accountable around addressing some of those social determinants of health with those patients that they're seeing, because those are the things that are hindering them to be adherent when they're coming back and forth to this doctor, and why they're missing the doctor so often. And a lot of times it ain't because, they just don't want to come. It's because they're hungry, they're homeless, or they ain't got no child care. There are a lot of issues that they're needing, but then being more lenient on how do we provide those types of services, and then taking it to them. That's why we have a mobile unit now, and we're looking to get more mobile units so that we can start bringing the mobile units to the community. We gotta provide it. We got to provide it in the community where they're at. Because, again, sometimes folks don't even want to come out of their community because of the chaos. You see the shootings that are happening right here up the street, right? You can't even sit at the bus stop, right? And so we got to bring it to the community as well.
I would add to that, too. I think, it's really critical that we make sure that the voice of the patient is heard in the medical complex, right? I think so often we look at the doctors as the end all, the be all, right? And of course they have the knowledge. We appreciate them. We appreciate their specialties. But oftentimes the client knows their body, right? And so teaching clients how to be advocates for themselves is a key point of what we try to teach, right? That you can advocate for yourself. And you can talk to your doctor, right, and tell them, how do you feel when they put you on this medicine versus this medicine? And if it's not working for you, how do we change that? Give me some options, right? And having conversations with patients and not just talking to patients, which is oftentimes what doctors will do. I think in the research space, what we are very, very, very clear on is that research has to start with community. It has to start with community input. So often researchers will come to us with research ideas and projects where they've already formulated that, right? And we're the last checkbox that they have to have, and so we have to have some community input. So now we're coming to you to tell us, what do you think about what we formulated? And we say, no, we want to help you build that research. We want to help you think about, you know, the process that you're going to use, and have community in that process all the way through is such a critical part. I think so often when mishaps happen is because we haven't included community enough. And I, you know, again, working with Fred Hutch, I'm lucky enough that I review some of those NIH grants, right, before they go in, and I can give my input and say, no, you don't have enough community research, community engagement, you know, it needs to be here. You're not using the right language, right, to reach that certain community. And I was just on a forum at the UW on last Friday. One of the things I said is that you got to tell them to build community relationship, right? This isn't a one-off. We don't want one-offs. We want relationships, right? We want to know what the research, once you finished and completed it, what did it mean? What did it do? How is it benefiting our community, right? So you have to come back and tell us, you know, what that research was able to accomplish. And so having us through it, through the through line of it, and building that relationships with community is so critical. Again, to that paradigm of having it be an art, right? That you just can't come to us when you feel like we need this population because we're trying to do this set of research or this study. But no, building that relationship with us all along the way.
Yes, sir.
I know that was what my job was with working with the clinical trials early on, was just communicating with the people of color, African Americans specifically, about clinical trials, because the fear factor was definitely there for obvious reasons, and not wanting to be a guinea pig, and you know, so just really just talking about what it was, and how the the safety, you know, things were in place now that weren't in place maybe in other times, and also the fact that so many African Americans, I so surely myself, didn't even know that all of the medications that you could purchase over the counter in the drugstores and places have all been through the trials. We never got that information as African Americans. We never participated in trials because the education wasn't there to say, you know, would you like to participate in a trial? And so being able to learn what's available and how it will help, you know, initially. Now, you know, we have many more people, and how important it is for, you know, black people to be in a trial, if they, you know, if they understand and want to be in a trial, and to be able to get the information about what's happening with our bodies, and how this medication and other things will impact us possibly. So the clinical trials have definitely grown in every manner. So we know that we have people that are involved in them, and now for POCAAN to be involved in the different researches and clinical trials is awesome.
Yes.
I think we have time for one last question. Well then, please give a really warm welcome to tonight's panelists. Thank you so much.
Okay, I just wanted to say, oh, sorry. I just wanted to say one last thing, which is thank you to the panel, and thank you to MOHAI for hosting us tonight, and a really warm thank you to everyone who attended online and in person. And I want to bookend by saying that if you were inspired by the history, the present work, and the expanding future of POCAAN, and you want to support us, please visit our website, which is POCAAN.org, or email me at Claudia@POCAAN.org, or come see me after the presentation. Thank you so much.
Thank you.
And to extend the goodbyes just a little bit. Tonight's program is on will be on the MOHAI YouTube channel. There will also eventually be a transcript, so you can find a great resource. Really incredible history shared here tonight. Thank you so much. Please do check that out. And if you'd like to help MOHAI continue to do the best in public programming, please consider taking our survey. We have little Lindor truffles available as an incentive, so that would be really helpful. And finally, History Cafe as a series will be on hiatus. We're taking a little summer break until September, where we will be joined by Professor Nalini Iyer of Seattle University, and she will be giving a talk about South Asian American resistance and literature. So it should be a fascinating event. So, yeah, please do check that out, and thank you all so much for coming.
All right, thank you.